4 fantastic speakers, and 3 of them are virtual, so fingers crossed. We've got a few minutes. We will start on, we got 1 minute. We will start on time. And I'm certainly on the edge of my seat, hoping the technology will deliver. So the order we're going with, I think, is we will have Michael Failings first, then followed by Ben Davis, and then not quite sure, Chad or Lindsay. It's Chad, then Lindsay. Okay, fantastic. And given times, we won't do lots of introductions because I'm a bit nervous the tech might not work. So we are on time now, and we're due to start. So I'm kind of hoping that we can kick off straight away with Michael. Yeah.
Hello, I'm Michael Failings, Professor of Neurosurgery at the University of Toronto, and it's a pleasure to take part in this special symposium at BritSpine, and I only wish I were there to enjoy this fantastic event with yourselves. So I'm going to speak over the next few minutes about some future directions and challenges in managing degenerative cervical myelopathy, and I thought I might take this specifically kind of through the lens of both the patient and the clinician in the context of the challenge of managing mild DCM. So I have no relevant disclosures. I have founded a spin-off biotech company, but this is not related to the content of today's talk. And I just wish to acknowledge the session co-leads, Elaine Buchanan and Leanne Wood. So degenerative cervical myelopathy encompasses a variety of benign, non-neoplastic, non-traumatic pathologies, the 2 commonest of which are cervical spondylotic myelopathy and ossification of the posterior longitudinal ligament. And this, if you will, sets in motion a cascade of events that can be reflected as a slow motion spinal cord injury. And we recognize that the pathophysiology includes static factors, including compression and ischemia, dynamic factors, as well as biomolecular factors, including inflammation, ischemia, and excitotoxicity. But clearly, much further needs to be known about the pathobiology. Over the last several years, our group and others have validated the use of the modified Japanese Orthopedic Association scale, which is shown in this slide, in the classification of mild, moderate, and severe. And we classify function based on motor dysfunction in the upper and lower extremities, and sensory dysfunction in the upper and lower extremities, as well as sphincteric dysfunction. Now, this has been a major advance in terms of having a validated outcome measure for DCM, but it's also exposed key knowledge gaps, and we need better outcome measures, in particular for patients with mild DCM. And in addition, the modified Japanese Orthopedic Association scale does not encompass measures of pain, which increasingly have been recognized as an issue of significant importance to at least 50% of patients with DCM. In 2017, we issued the first clinical practice guidelines for DCM, which were published in the Global Spine Journal. And we, for the first time, really showed very convincing evidence of the effectiveness of surgical decompression. And this shows the forest plots at 6 to 12 months, up to 3 years, and beyond 3 years, showing very large effect sizes for surgical decompression. So based on this, there was a very clear recommendation for surgery in patients with moderate and severe myelopathy. But mild DCM remains an area of some controversy. And here, there appears to be equipoise in terms of recommending surgery or a trial of non-operative management. There's a lot of shared decision-making that occurs. And in my view, this represents a significant opportunity for research to fill this knowledge gap. So we need a personalized management approach for mild DCM with improved clinical prediction, a better understanding of the natural history, improved outcome measures. The use of microstructural MRIs and imaging biomarkers is a significant opportunity, and we need to consider genetic and serological biomarkers to try to evolve to a personalized medicine approach. And underlying all of this, we clearly need a better understanding of pathophysiology. So let's consider this case of a 67-year-old woman who comes in with mild neck pain and a clinical picture of early myelopathy with multi-level degenerative cervical spondylosis. So how should we manage this person? And I'll show you toward the end of the talk what I in fact did. So these are the axial images showing fairly impressive cord compression. But interestingly, her neurology was still relatively mild. So let's consider 3 clinical scenarios. So what if she had minimal neck pain, cervical stenosis, and no neurological symptoms or signs? Or if there was minimal neck pain with cervical radiculopathy and cervical stenosis, but no myelopathy. And then the clinical case, as I showed it, minimal neck pain with evidence of an early myelopathy. So again, by way of background, we consider the issues that cause this progressive cervical cord compression. In this case, is cervical spondylosis, but we have a variety of other pathologies, including OPLL and other entities. We recognize that DCM is the leading cause of spinal cord dysfunction globally, and it's a form of non-traumatic spinal cord injury with cord compression and progressive spinal cord ischemia and inflammation. So operative versus non-operative management. Here we have another case. And again, we might consider the different scenarios of neck pain, no myelopathy, radiculopathy, and minimal myelopathy. And how on earth should we interpret these T2 signal changes? It's quite concerning. Well, microstructural MRI may provide a part of the answer. And so we have a few metrics. T2 weighted imaging with T2 star imaging, and we can look at the ratio of this. This is quite an interesting outcome measure. Magnetization transfer to look at demyelination, diffusion tensor imaging, and the one that I particularly want to leave you with is this T2 star weighted white matter to gray matter ratio, and this is of particularly important relevance. The Spinal Cord Toolbox, developed by Julien Cohen-Adad at the University of Montreal, is a freely available toolkit that any radiology clinic can use to try to bring these microstructural techniques into the clinic. This is the publication for this T2 star weighted white matter to gray matter signal intensity ratio. This was Alan Martin's PhD work when he was a student in our group in Toronto. This shows some of the images here. One can actually do microsegmentation of the cord using Julien Cohen-Adad's techniques. And this very simple ratio of T2 star weighted imaging reflects demyelination, gliosis, and other pathologic changes. This was an attempt by our group about 10 years ago to summarize some of the literature related to the pathobiology. And we recognize that ischemia resulting in endothelial cell damage, blood spinal cord barrier disruption, as well as glutamatergic excitotoxicity causing apoptotic cell death were critical elements, but clearly much further needs to be known. In the spine focus issue, again, from a decade ago, we summarized the surgical techniques. And really, these are very effective. But again, the knowledge gap is how to manage mild degenerative cervical myelopathy. And we need to have a better knowledge of the natural history. This is John Rhee's systematic review that our group was a part of. And we recognize that about a quarter of patients will deteriorate over about 4 years. And those with symptomatic degenerative cervical myelopathy have a much higher rate of deterioration. Cervical stenosis with no overt myelopathy, but with evidence of radiculopathy and neurophysiologic changes suggestive of nerve root compression, have a poorer natural history, as summarized by Paul Matz's article. So again, we come to these recommendations for mild DCM, and here we again have the equipoise between operative versus non-operative management. And this requires a significant amount of judgment and shared decision-making. So if we look at the outcomes of surgical decompression in mild DCM from a large prospective data set in which we have combined a number of prospective studies of of DCM, specifically the North American international studies, we examined 193 patients with mild DCM, and we looked at the functional outcomes as well as the baseline characteristics. Patients with mild DCM can have significant impairment in their health-related quality of life, as assessed by both the physical and mental component scores of the SF-36. Surgical decompression does improve function, disability, and quality of life in these patients, but the outcomes are quite heterogeneous, and we see that about half of patients have an excellent result, and about half of patients, the results are okay, but not stellar. So why is this? And so here we need to start thinking about the use of techniques such as machine learning algorithms to try to understand the clusters of effects that might assist with clinical prediction. And it turns out that older patients and patients with a lot of medical comorbidities, and interesting, smoking is a negative predictor of functional benefit in patients with mild DCM. And then again, interestingly, patients who have an anterior approach appear to do better, probably because the outcomes with pain are improved with an anterior approach. So this illustrates kind of how patients are doing with mild DCM. And we see here that the physical component score of the SF-36 and the neck disability index are two metrics that you could use to assess responders. And so if patients have poor health-related quality of life and have a significant amount of pain, they will report substantial benefit with surgery. So how do we manage this patient again with mild myelopathy and multi-level cervical spondylosis? Well, I did a multi-level anterior cervical approach, and fortunately, she had an excellent outcome with a full recovery of function. Mild DCM may not always have a benign prognosis, and this is a cohort of patients that we followed in our clinic in Toronto, where largely patients declined the option of surgery. We found that over about a 2-year period, 50% of patients had a significant enough decline to warrant surgical intervention. We need to know more about genetics and serological biomarkers, and this is work from our team with the use of ApoE4 potentially as a biological outcome a measure which can influence the outcomes of degenerative cervical myelopathy. And ApoE4 has also been linked to the risk to develop Alzheimer's disease. So in conclusion, surgical decompression is safe and effective for mild DCM. Mild DCM reflects a heterogeneous population, and decision-making in mild DCM is a shared decision process. Pain is a big driver and is important to recognize, and the SF-36 is a useful instrument to assist in decision-making. Future clinical decision analysis will benefit from new approaches, including machine learning and artificial intelligence approaches, the use of microstructural MRI, and genetics, including potentially the assessment of ApoE4. Improved outcome measures are needed, and we need an improved understanding of pathophysiology, and we also need improved non-operative approaches, including neuroprotective and neuroregenerative strategies. And on that note, I'd like to conclude and happy to take questions.
Can I urge you to jump up quickly for questions if you have any?
No, he's recorded. He's not live.
Oh, good. At the end,
We'll have him at the end.
Okay, thank you. Good.
Right, so I'd like to introduce Ben Davies, who is a neurosurgical registrar and one of the co-founders of myelopathy.org, as well as AO Spine's Recode. He's also one of the co-leads for Received Myelopathy and Polyfixed DCM. And he's the founder of MoveMed.io. So we feel very privileged to have him here today. Thanks, Ben, for coming.
Well, thanks very much for joining, and pleasure to make this one in person. So it's a long title, but really hoping to pick up on what Michael's been saying, which is that whilst we've made tremendous progress, the sobering reality is that this is still a life-changing diagnosis. And what I want to share with you today is that really, if we would move forward, faster and further, we need to think differently about DCM, and we need to work collectively. The greatest challenge is limiting our surgical outcomes, our patients' lives, and our problems that lie outside of the operating theatre. And ultimately, that means we need to work harder to bring a different perspective into DCM, one that can help solve those problems, but also, perhaps more importantly, move the solutions back into clinical practice, which is probably the biggest challenge for DCM. So in this talk, I'm going to introduce something called Recode DCM, which started off life as a very well-defined project to provide a common language for how we research in this field, ultimately trying to solve the problem of making sure that innovation anywhere can transform outcomes everywhere. But it's really grown now into a global community of people, ultimately, thinking differently and working collectively. And it's a community that's very much open to lots of different people, and it's a community that's really the sum of all of its individual parts, and there's lots of people who should be acknowledged for bringing this forward, and it was something that me and Mark dreamt up. Mark's at the front somewhere here. A long time ago, Brian Kwan's here, who alongside Michael Failings helped persuade AOSpine to back it, and I will mention Liz as well as the front, who's now the project manager for the community. So there are lots of great people, and many more should be thanked as well. But let's start off with what we thought was a problem at the beginning. So when we started to get into this about 8 years ago, what we saw is that actually researching DCM is quite difficult because the field is quite small and it's very spread out, poorly connected. This network statistic shows individuals who contributed 5 articles to DCM over the years, and you can see that most people are working in isolation. There are some very large activity hubs, but they're generally defined by countries, and that lack of connectivity was potentially creating lots of challenges for how we bring research forward. And one of them was that we actually couldn't agree what to call the disease. If you walk around the world, people talk about this in many different ways. There are 11 different names used in the literature. We conduct our research, we measure the disease in different ways, and they're subtly different, but ultimately that's important because if we can't compare studies like for like, we can't interpret them. So progress in one part of the world struggles to change practice in another. And also there's a question perhaps that me and Mark started to see more and more working with myelopathy.org is that perhaps our priorities as surgeons weren't 100% aligned with those of the patients. And in the survey of almost 500 people living with myelopathy, we asked them what was their recovery priority, what would we most like to have changed. And whilst improving their walking, improving their hands was important, as Michael's picked up on again, pain actually was the #1 recovery priority. And that was a sort of contrast to what was being researched. Very rarely did we measure pain to that point in our trials. So we sort of had this sort of picture. We had some activity, lots of duplication, people fighting, get alongside each other, some perhaps open knowledge gaps that needed to be solved. And so me and Mark started to think about how we could try and find a common language that would move this forward. And we came up with this project, AOSpine Recode DCM, to try and provide a common framework for how we could all work effectively together. And of course, this is all it's trying to solve these sorts of problems, that we have limited recovery, large amounts of dependence, some poor quality of life. And I think I'll just show you this. It's not projected very well at all, but this is some data we've just put together from the United Kingdom. But if you take what you predict to be the prevalence of myelopathy and look at what we actually diagnose in the UK, the answer is we diagnose less than 10% of this condition. So there's some big confidence intervals in that, but that is the size of the problem we're trying to address. And of course, as I mentioned, we're a small field. We've just attracted $47 million worth of investment since 1995 against the billions of dollars in multiple sclerosis and much rarer conditions like motor neuron disease. That makes all of these challenges of inefficiency much, much greater. So this Recode project was essentially 3 consensus projects to define 3 things: what to call the disease, how we should conduct our research, and importantly, what we should be researching. Big team, lots of people, and a very quick flash of acknowledgements there. But ultimately, worked very hard to get a different audience to contribute. And we had over 68 countries represented, 17 different healthcare disciplines. And I think that diversity was one of the key lessons we take away from this project. Lots more detail online, but I will flash through, obviously, the results, the headline results. So what to call this condition? Well, I think the talks are giving it away, but we ultimately settled on degenerative cervical myelopathy. And it wasn't something that everyone bought into initially. Lots of different ideas, lots of different conflicting ideas about what this should be called. But the eventual conclusion was really settled by, this is a name which has increasing adoption, has no legacy of confusion. The big challenge for CSM is that lots of people think it includes OPLL, some people think it doesn't, and that's a bit of a problem with interpreting data. But I think importantly it sets out to be an umbrella term that recognises that subpathology are probably going to be important as we move forward. In terms of what to measure, again, intensive iterative process, but just to re-highlight why this is so simply important. Imagine you're booking a flight on holiday, and you're on a price comparison website to look at the data, and you want to see certain critical pieces of information displayed to help make the right choice for you. Now, if I take away certain bits of information, it makes it very much more difficult to understand whether the second flight or the first flight is going to meet all of your requirements. And research is exactly the same. Unless we see the same data presented side by side, we can't make those interpretations. And so structured process and a lot of detail online. It's easier to read online. But ultimately, the summary is in terms of measurement, these are 4 critical outcomes that should be included in trials for myelopathy. Something called the MGOA, the SF-36 for quality of life, the NDI you've heard from Dr. Failings there for neck pain, and adverse events measured through a system called SAVES-2. But on to perhaps what I think is potentially the most important contribution of this so far would be defining the knowledge gaps. And so this was a James Lind Alliance process. It asked all of those different people for their research ideas, it consolidated them down into single questions, and then we would essentially prioritize those into a top 10. And that was initially online, and then with a group of people, diverse group of people in New York a few years ago. And so in reverse order, the priority number 10 is about how we individualize surgery. And this is about, as Dr. Failings picked up on, moving to a position that we understand the factors that help us decide how and when in that individual circumstance. Again, as Dr. Failings has picked up on, perhaps helping that will be advances in our imaging, microstructural MRI, for example, and indeed also the neurophysiological assessment. Priority number 8 is the need to define the socioeconomic burden of this disease. At the moment, we haven't really characterized the financial impact of this condition, which should be significant. We've got high levels of disability, therefore surely high levels of dependence, loss of taxes, etc. And I think until we've characterized that financial pain, governments, policymakers aren't really going to wake up and invest in this area. Priority number 7 is the need to develop new treatments, treatments to repair the spinal cord, to mitigate the disability that we see. Priority number 6 is probably a big open goal, perioperative rehabilitation. Despite close parallels to things like traumatic spinal cord injury, there is no structured rehab at the moment for people with myelopathy. It's a bit ad hoc, it's not coordinated, and ultimately could start before surgery. And this seems to be a big open gap that we could do some very simple things very quickly. Priority number 5, again, picking up on themes already mentioned, is the need to understand exactly what drives injury. Priority number 4 is about understanding how we can measure the disease better, because again, this is important for looking at those patient trajectories to help treatment decisions, but also in terms of measuring outcomes, in terms of trials, and ensuring they're done as efficiently as possible. Priority number 3, we're going to hear a little bit about more, but ultimately, we can't agree, probably in this room, exactly what constitutes cervical myelopathy, and if we can't agree, and ultimately we can't teach and educate other people to make the diagnosis for us, and that's a big gap to be solved. Priority number 2, which again I think picks up on where Dr. Failings is taking his lens now in terms of early surgery, is really understanding how this disease starts. What defines somebody with no symptoms to symptomatic spinal cord injury? And ultimately, if we can get that knowledge, we can move surgery to a position perhaps where people have prophylactic surgery perhaps. But underpinning all of this is a great lack of awareness. People don't know about this condition, they've never heard of it, and that makes it very difficult to diagnose, to get referred, to seek support and education, and that's felt at every level. And ultimately, until we have awareness, we don't have investment, we don't have a research field, the whole thing is strongly limited. So there's lots more about these priorities online in what I think is quite a well put together podcast series, lots of experts contributing to say why this is important, how they think it should go forward, if you want to have a listen on the way back from Glasgow. But I think just to re-highlight that this is a new direction for the field. This graph shows essentially before the priorities where research activity was occurring, and you can see that most of the priorities haven't had much attention, and therefore this is a new shift in direction. And this is just a good little summary of that. But I think the biggest challenge, and we'll hear a little bit more in the next talks, is how we move forward and how we plant those first seeds. And this is something shared with me by Brian, I know I can see in the audience now, a proverb about, if you want to go fast, you go alone. If you want to go far, you go together. And I think that's a key message for us now, listening to Recode. How we get from this position to a field full of activity. And something we tried to put together is a program called the Incubator Program, and it comes under this umbrella now of moving Recode from a project to a community. We're going to pick up on 2 of those incubators in a second, but essentially it champions that same idea, diverse, global perspectives coming together to solve new, unexplored problems. And just a sort of summary side about the 3 groups that are being led by these individuals. Again, you're going to hear 2 in a second. But very much an open invitation. If you're somebody in that area, you feel that resonates with you, we'd be great for your contributions. So yeah, I'll finish there. Thank you.
Gosh, what an open area for for research, really. Society of Back Pain Research will be keen to be involved and support this for sure. But next up, we've got Professor Chad Cook, who's presenting remotely. He's a professor of Department of Orthopedics at Duke University, director of the Duke Center for Excellence in Manual and Manipulative Therapy, and leading the ForceNet and U24 network grant. So, Chad,
well, greetings, everyone. My name is Chad Cook, and I'm a professor at Duke University in the United States. I'm also the RECODE DCM Perioperative Rehab Incubator Chair. Today I'll be talking to you about best practice recommendations for pre, peri, and postoperative rehab for individuals with DCM. Very briefly, my background, by clinical training, I am a physical therapist, but for the last 23 to 24 years, I've primarily been a researcher. My research concentration has been as a trialist and as a big data researcher. In fact, I've had the ability to tap large surgical outcomes data sets because I have a very strong biostatistical background. I first published in the area of DCM in 2008. My earliest works were in diagnostic accuracy and general surgical outcomes. And lately, we've been looking at pain related to individuals with DCM. I was appointed as the perioperative incubator chair in 2021. The charge for our incubator group was to first build a working group of individuals that were not only interested in producing information for clinicians, persons with DCM, and policymakers, but also had the experience in doing that. In other words, they had experience in managing DCM. Also, we're very interested in creating best practice recommendations for management of pre, peri, and postoperative DCM surgery. Over the last 15 years or so, we've seen a significant improvement in surgical techniques and in surgical outcomes. But we haven't seen the subsequent improvement in how we manage these individuals on the rehab side. This information just simply is not in abundance in the literature, and our goal is to contribute toward that. Our hope is to publish the work and help implement these findings for clinical practitioners. Well, our first charge was creating an incubator working group. And we've a very exciting, very motivated group of individuals that include neurosurgeons, physiotherapists, DCM researchers, occupational therapists, physical medicine and rehabilitation physicians, nurses, pain management specialists, and these are individuals from all over the world, multiple countries. We also, and potentially most importantly, have people with lived experience with DCM, and they have really set the guide rails for us by discussing some of the challenges they had during their management process and the gaps of care which they think should be improved. We're using something called a consensus development panel, or a CDP, and you may be familiar with this type of methodology because it's used to create clinical practice guidelines. In fact, typically it'll take anywhere from a year to 16 months to create a clinical practice guideline, and our attempt is to complete this in anywhere from 6 to 8 months. Our panel members include about 15 for each of our 3 timelines, but we know that with CDPs, they can consist of anywhere from 9 to 20. Most importantly, they need to include individuals with a variety of different backgrounds, which we have, including both experts and individuals with lived experience. Again, we have that as well. It's important to recognize there are a series of progressive steps with CDPs. We're attempting to tackle this virtually, and we have a number of subgroups that are working on the different domains that we've identified as a group. I want to emphasize something. Consensus does not mean total agreement. So our guidelines that we'll provide recommendations that were based on consensus and are likely to change as clinical information continues to grow. One of the first things we recognized as a group is that the timeline of perioperative management was simply too large to really reflect the granular nature of what we would like to create in our clinical practice guideline. So we have broken it down to 3 groups. Preoperative, and that's from the point of deciding to have surgery to the point of admission to the hospital or surgical center. Perioperative, which is that hospital or surgical admission to 6 weeks post-surgery. And then postoperative, which is 6 weeks post-surgery until normal function has been restored or until that patient meets a maximal rehab benefit. Interestingly enough, this has been our probably most contentious point of discussion so far, but these are our timelines that we're shooting for. The domains of interest for each of these papers will include general health management, treatment parameters for physical and occupational therapy, education on disease, trajectory, complications, and a core information set. We'll work in synergy with other RECODE incubators that are working on clinical decision-making support tools, recovery and discharge planning, pain management, quality of life optimization, and then also surgical planning and expectations. As I mentioned, our end product will be 3 papers that outline the granular best practice recommendations. We realize there are narratives that are currently out that talk about treatment for physical therapy or rehab, but it's important to recognize that we don't feel that those are granular enough. We want specific recommendations that will allow clinicians to clinically transfer this into their own practice. By the way, if you haven't visited myelopathy.org's website, I encourage you to do so. This is an amazing group of individuals who are volunteering their efforts to do the right thing, and I feel very, very privileged to be part of their efforts. Thank you very much, and have a great conference.
Yeah, good. Chad, I don't know if you can still hear me, but we're hoping to wait for questions at the end once we've had the last speaker that Lillian's going to introduce.
Sorry, 2 seconds.
Or I can jump in and do it.
Okay, do it.
Yeah. So the next speaker is Lindsay Tetreault, who's a neurological resident at NYU Lansing, New York. She's got extensive experience in guideline development and is involved directly in primary imaging research. So, Lindsay, I'm hoping the magic of technology, you will now appear.
Good morning. My name is Dr. Lindsay Tetreault, and today I'll be talking about developing diagnostic criteria for degenerative cervical myelopathy. As we all know, DCM is an overarching term used to describe progressive compression of the cervical spinal cord by age-related changes to the spinal column. Patients with DCM can present with a wide variety of symptoms, including substantial neck and arm pain, loss of dexterity, bilateral hand paresthesias, gait impairment, and bladder or bowel dysfunction. These symptoms result in significant functional impairment, reduced quality of life, and loss of independence. Importantly, the prevalence of DCM is estimated to be 2.3% and is anticipated to rise with the aging of the global population. Despite its prevalence, patients with DCM experience significant delays in their diagnosis. This was a study published by Hilton that reviewed the diagnostic pathway in the United Kingdom and reported that the time between symptom onset and primary referral for DCM was approximately 8 months. Of the new cases, 76% were referred to an alternative specialist rather than directly to the spine surgeon, including a neurologist, physiatrist, or rheumatologist. The time between secondary assessment and surgical assessment was approximately 5 months, indicating that patients wait on average 17 months from the onset of their symptoms to be evaluated by surgeons for definitive management. This was a second study published in Israel that noted the average time to diagnosis was approximately 2 years, and that the majority of patients were initially assessed by a family practitioner. The most common diagnoses were carpal tunnel syndrome and cervical radiculopathy without neurological deficit, and the workup suggested for further evaluation included EMG in 84% of cases, cervical spine CT in 63%, and bone scans in 36%. A third study by Pope indicated that while 30% of patients receive a diagnosis of DCM within 6 months of symptom onset, approximately 1/5 will wait over 5 years. Why is the diagnosis of DCM often delayed, and what makes this so hard to identify? One of the main reasons is that patients can have heterogeneous presentations. They can present with subtle, non-specific symptoms in their upper and lower extremities, as well as symptoms that are also common in other neurological conditions, such as carpal tunnel syndrome or diabetic neuropathy. The natural history of DCM is also variable, so some patients have rapid progression of their symptoms within weeks, while others can have stability for a number of years. And then finally, many signs of motor and sensory dysfunction are not overly sensitive or specific for diagnosing DCM, and the inter-rater reliability of these signs is also questionable. The second reason it's often missed is that there are limited neurological examinations that are performed within a primary care setting. And the reason for this is that GPs often have 10 to 15 minutes to see a patient, and a detailed neurological examination can take over 5 minutes to perform correctly. There's also a concept of neurophobia, which may occur among primary care physicians, which is defined as an aversion to the neurosciences due to perceived difficulty. Third, there is a lack of professional awareness, and this was portrayed by this study by Benjamin Davies, which looked at the number of references to degenerative cervical myelopathy, as well as the word count devoted to degenerative cervical myelopathy in various curricula, as well as learning resources. And as you can see here in the curricula analysis, the number of times DCM was referred to was 4, whereas diabetes was 252. In terms of the word count devoted to DCM, across the learning resource analysis, there was 1,100 words devoted to this condition, whereas for diabetes, it was over 14,000. There's also a lack of patient awareness of this condition. So patients, before coming to a primary care physician or another specialist, will often use web-based symptom checkers to determine a list of potential diagnoses. And in my experience, a lot of patients will come into the office and say, doc, I think I have carpal tunnel syndrome, or I think I have nerve root compression in my neck. And this is because of the available information on Google, WebMD, and other resources online. Now, in a study by Benjamin Davies, 31 symptoms of DCM were entered into these web-based symptom checkers, and only 45% of the symptoms that are of these symptoms listed DCM as a possible diagnosis. And so, while there is a lack of professional awareness, there is also a lack of patient awareness of this condition. So what are the consequences of delayed diagnosis? Well, certainly this results in significant disability, which has been demonstrated in this study that compared myelopathy severity, dependency, and employment data for 800 patients with DCM and stratified their cohort in terms of time to diagnosis. What this study found is that patients who waited longer for a diagnosis tended to be more severe, were more dependent on caregivers for their activities of daily living, and were more likely to be unemployed. Delay in diagnosis also results in incomplete postoperative recovery. I've certainly spent a number of years looking at important clinical and imaging predictors of surgical outcome in patients with DCM, and one of the most reliable predictors of outcome is actually duration of symptoms. As you can see here, we dichotomized our group into a long and short duration of symptoms group at a number of different cutoffs, and consistently, patients who were in the long group compared to the short group had worse outcomes in terms of their change in MGOA score at 1 year. So I hope I've convinced you that there is a clear need to develop diagnostic criteria for DCM due to the heterogeneous presentations, the prevalence of the disease, and because this disease is often misdiagnosed initially. Diagnostic criteria do serve to improve patient care by facilitating earlier diagnosis and treatment. They act as a reference tool for primary care physicians and other specialists who encounter DCM. They can serve as a basis for developing a triaging and surveillance system, and they can certainly help to standardize research studies. In terms of our proposed methodology, we are working to generate candidate criteria. This will be followed by defining and reducing the criteria and then weighting the criteria. In terms of generating candidate criteria for inclusion in diagnostic criteria, we are conducting systematic and scoping reviews of the literature to look at the diagnostic accuracy and frequency of various symptoms and signs in patients with DCM. We're conducting a survey of individuals with lived experience to ask them what their very first symptom was, as well as what symptoms they currently experience as a result of their myelopathy. And then finally, we're doing a survey of international experts, asking them what they believe should be included in diagnostic criteria. From here, we are assembling a multidisciplinary group of experts in DCM in order to reduce the criteria, and this will be done using a nominal group technique. And then finally, using case vignettes of patients with DCM, as well as case vignettes of mimicking diagnoses, we will weight each of the criteria. So I make no promises, but I anticipate that these diagnostic criteria will be completed by the end of 2023, and I'm hopeful that I will be able to present this at a future conference for you all. So thank you very much for your time, and I'm sorry that I could not be there in person.
So my understanding is that, well, I'm sure we have Ben here. My understanding is that we have Chad and Michael. Fantastic. That's great. So I'd very much welcome, we've got some time for discussion. I'd welcome some questions from the floor. And I've been thinking hard just in case people are a bit shy. So one of my questions, I think for everyone in a way, is how do we determine the threshold for imaging in this group, given we know there's some potential iatrogenic harm from imaging and that it's costly? And it seems like, you know, the biggest priority in a way is pain. So I'm just thinking about those primary care community practitioners with people presenting with pain in the right age group. You know, that seems like an important thing to think about. What's the threshold for investigation via imaging, for example?
Maybe I'll have a go with that. Are you able to hear me all right?
Yep.
Perfect. Yeah, so we're in Canada, we're doing quite a bit of outreach to the family medicine group, and I collaborate with a professor of family medicine at National University, Jamie Middleton. I think the important idea here is to have an algorithm that GPs and family physicians can use to make the diagnosis. And it's important to make the diagnosis and then to confirm this by imaging. And so about 50% of patients will present with neck pain, but it's also important to recognize that 50% of patients with DCM will not have neck pain. So some of the flags of history are bilateral arm paresthesiae to provoke a diagnosis of DCM first, and not bilateral carpal tunnel syndrome, which is really should be a secondary thought. The second thing to screen for will be tandem gait, and if that is impaired, then that should raise the possibility of cervical myelopathy. And then on the physical examination, one can also check signs that might be suggestive of hyperreflexia in the upper extremities, including a Hoffman sign. So I think some of the constellation of these issues should then prompt imaging. And then once the imaging is done, a specialist referral can be undertaken to then evaluate what the best treatment options might involve.
Chad, do you want to follow up on that? Because I know you spent a lot of time with just that question, didn't you? The pre-MRI diagnostic battery you produced. Can you hear me?
Yeah, I think the real answer to this is spooling up the knowledge of primary care physicians so that they don't order unnecessary imaging, and they start recognizing this earlier so they can refer earlier. We did create a clinical prediction rule per se for ruling out myelopathy. It has had some traction, I think, in the literature and in clinical practice, but certainly not to the level that we had hoped. Not being an imaging specialist, I'll stop right there and punt that back to you, Ben.
I don't know about that. I mean, I think the practical challenges here are huge. I mean, GPs in the UK very rarely can access MRI directly, so a lot of it comes through neurology or interface clinics. I'm sure some of you sit in those here. I think, from my perspective, the threshold needs to be lower, but MRI is not a perfect test. So you have this challenge then of seeing a, partial clinical history, an MRI, which is difficult to interpret because ultimately core compression doesn't define whether someone has myelopathy or not. So I think it's a knowledge gap, to be honest, and I think the only way we can start to break that down is to lower the threshold to have an MRI. And I think to your harm question, I don't know the experience of you, Michael, or Chad, there's relatively low levels of, I'm not that aware of harm with an MRI. I can think of one a case report we've written, which is extremely rare, but it's a relatively safe, well-tolerated procedure.
I suppose it was more within the context, lots of discussion in non-specific back pain around the role of imaging and labelling and the like, and interventions. You see something and the temptation to do something about it.
There's definitely, I saw a great study from the US where, they get that report back, because often in the US, the healthcare system such, you go and see your MRI separately, you get the paper report and you see all these words and, oh my God.
That's the kind of harm I'm talking about, yeah.
I think this is a bit different, but I think we might have some lessons to learn from back pain there,
just experience from the East Anglia region, Ben's region, but down in Ipswich, we've got our single point of access where we have spinal ESPs out in the community doing the primary triage, and in fact patients can bypass their GP and just self-refer themselves in. And they not only have the national back pain and lumbar leg pain pathways embedded, but they also look after this as their single point of access, so they have the ability to scan and pick up. So I'm just thinking in terms of British accumulation of we already have the national back pain and lumbar leg pain pathway. You just need to incorporate, have very flyaway, flippant. We need to embed the same thing, because we pick up a lot of asymptomatic, perhaps that's why we're picking up in our region more asymptomatic, or do they, don't they? And we have conversations all the time with the asymptomatic cord compression all the time about a watch and learn, and they are being picked up. We're also picking up the carpal tunnels that are masquerading as well. But if they have neurophys, you kind of pick that up in that community interface. So you're appropriately guiding them, and you can also get them into you quite quickly once you've got them picked up that way. We're seeing them within a month or so in clinic to have that kind of shared decision making about, well, what do we do now? And obviously if they're clearly myelopathic and they got a moderate or severe, we're going straight into surgery. But it's tying up these bits that clearly the experts around the world have identified is how we are going to identify and then have the conversations. But actually, in the UK, we're very fortunate that part of that pathway should already be done with MSK interface services. So actually taking some of the role off the GPs and putting them in front of a spinal ESP, so extended scope practitioner, advanced care.
I'm going to risk shutting you down and being rude, just to say there are other questions, but I think the point is well made that certainly in the UK context, there are other practitioners in addition to general practitioners.
100%. Thanks very much, Alistair. And I think just on the point of pathways back pain, there's a very interesting study running from Switzerland at the moment called Screen DCM, which is actually routinely screening people with lumbar pathology for cervical myelopathy. And it's early results, but I think they've got 500 patients now. And in lumbar canal stenosis, they're seeing 40% who enroll have early myelopathy. So they're not getting the myelopathy that needs surgery, but they are diagnosing a whole population of patients that we've never seen before.
Sorry, so mine's a really quick one. I totally agree with Chad that the solution to this is education rather than trying to find a magical algorithm or standard threshold. So I completely agree with that. We do need to educate our primary care colleagues and non-specialist spinal colleagues. But also there's this massive debate going on in physio-osteo world about over-imaging. And I just wanted to make the point that myelopathy is closer to cauda equina than it is to back pain. It's a serious pathology. So if in doubt, scan. It's different to back pain because if you see somebody with back pain who you're not worried about, then imaging can obviously be harmful, equally with persistent neck pain and many other spinal conditions. But I would say if there's no red flags, you're not concerned about the cord or anything sinister, then have a very high threshold for imaging. Why would we image them if it's not going to change anything? But if you're worried about cord or cancer or cauda equina, have a low threshold for imaging if you're concerned, because we don't want to miss these. We don't want people to be paralysed from the neck down and doubly incontinent just because we're worried about our imaging rates.
Thanks, Julia. Yeah, 100% agree. Just one other quick comment on that. I think it's also important to recognise that access to MRI is difficult. So regional differences exist, but I know, we did a lot of pathway analysis in the east of England. People can wait 6 months for an MRI. So, they've got to reach for the trigger for an MRI, and then you've got to wait for the MRI, you've got to wait for the MRI report, and very quickly you're at a year before you can move that patient's care forward. And I think that's an outlier, but ultimately, similar issue.
We've got another question at the back. Thank you.
I think rehab for post-op patients is virtually non-existent, as far as I'm aware. Is there any evidence that post-op neurological deficits are improved by treatment? For example, is neuroplasticity involved?
From DCM specifically, the answer is no. I don't know, but there is, you look at traumatic spinal cord injury, Dr. Failings can probably speak better than I on that. Then the parallels are similar, and the answer is a yes, and Brian's here as well. It makes logical sense to me that we should be seeing some gains. And ultimately, the surgery triggers quite a big amount of plasticity in these patients. They haven't got quite, the devastating injury of traumatic spinal cord injury. So when you look at the recovery trajectories, most of the recovery occurs by 3 months. So you've got this window, I think, where there is an opportunity to enhance and promote. And I think we are missing it, yeah. I don't know, Dr. Failings, you want to add anything from...
It's an area that requires, investigation. So post-operative rehabilitation is very commonly done, and it's arguably kind of a standard practice. But the strength of the evidence could be better. So that in 2017, we actually critically examined the literature for traumatic spinal cord injury, where there's probably the greatest evidence for rehabilitation. But in terms of the grade criteria, the actual evidence around rehabilitation is lacking a bit. That's not to say that it's not of value. I think in DCM, there's a tremendous opportunity to develop validated rehabilitation protocols. And I like the idea also about this concept of enhanced recovery after surgery, or ERAS. This is becoming quite popular in North America. I don't know if it is taken off in the UK, but it's really popular here. And in particular, patients who have mild myelopathy, let's say that you may be considering surgery, a preoperative course of rehabilitation, smoking cessation, dealing with mental health issues, these sorts of things can be quite helpful. Well, Chad, if you want to perhaps comment as well.
Yeah, I agree with both Michael and Ben. Unfortunately, it's just the research is missing in rehab right now. And our initiative is going to be to essentially put the structure in place of what needs to be studied and use expert opinion, because essentially that's all we'll have right now. And then perhaps we can move forward from there. Hopefully this will be an initiator to get people out there to do research on it, but it's just missing. And it doesn't mean it doesn't work, it's just missing.
Mm-hmm. And just one other advert, really. We're going to talk about this a lot more tomorrow morning at the breakfast seminar, if you can join us, because I think the knee-jerk reaction with rehab is to think physical therapy, but I think there are many other, as Chad's outlined, simple things. Education is one. These patients are lost after their operation. That's why we set up myelopathy.org, and there are lots of simpler things, which again can come in quite quickly.
And if I can just add to that too, I think there are pockets of good practice around the UK, certainly, where there are neurological physiotherapists and MSK physiotherapists who are rehabbing these patients, but they haven't been published and there isn't a lot of data on them.
Mark, are you
Yeah,
poised?
I just want to make a point about how important patients are in all these endeavors. Because if you look about, there's a number of huge questions that we haven't gotten an answer yet. So why is it that the SF-36 scores, why is quality of life in these patients so bad? We know about the symptoms, but what's the driver of this quality of life? If you don't know that, you don't know what you want to rehabilitate. So this is a key question. The other question, just commenting on what we did before, said before, how do we implement change? And I've learned that there are some very advanced setups in the UK, Nottingham, a streamlined pathway. I could only dream of a streamlined pathway for DCM in Cambridge. I'm still fighting to get them sort of just fast-tracked a little bit, these patients. So, but this is a thing that occurs in other areas as well. And often, cancer is a good field, for example. There's enormous amount of innovation in cancer, but not all the innovation is being brought to the patients because of expert opinion, uncomfortable embracing new approaches. And again, I think what now is taking place is that there's direct communication of people that have solutions to the patient group. And the patients rock up at these centers and said, I want X, Y, Z. I've read about it. And I think that's really the power of myelopathy.org as well. We can directly educate the people that actually want most of these changes. And they need to help us to leverage and put into place those important changes that, for example, you've done in Nottingham. I think, so my point here is, let's work together even more with the patients to drive change, but also to find out what's important for them.
Thank you.
Thank you. There's one more question.
Hi there, Alexander Montgomery. I'm a spinal surgeon in London. So I see quite a lot of young people and sportsmen, and for one reason or another, they get an MRI scan because they've had a bit of neck pain, it's gone, or they had a bit of radicular pain, it's gone, and then they've got cord compression, they're a rugby player, they're a boxer. What conversation, I guess it's Michael Failings, director that, do you have with them? Like, do you say your career is over? Do you say, well, actually, unless you have an operation, you can't carry on? Can you do an operation on an asymptomatic cord compression for sport? It's a problem that I sort of come up against quite a lot, and obviously they go for a second opinion and someone else gives a slightly different opinion, then you're trying to look for a reason to intervene, and you're kind of stuck there because you're giving this guy, a young guy, no options really. You're telling him either your career is over or you're going to have an operation, and even then, I can't guarantee you're going to get back to what you're going to do. I was just wondering how you approach that.
That's a very tricky topic, and we've tried to summarize the literature on this publications to develop kind of guidelines to assist physicians in these types of recommendations with regard to return to play criteria. And, in a nutshell, it will depend on whether or not there was a cord injury, was there signal change in the cord, is there ongoing compression, is there cervical stenosis, and then it'll depend on the type of sport. So, is it a collision sport such as soccer, or football, or basketball, or is it a violent sport like hockey or rugby or American football? In the latter case, from a legal perspective, if you're an athlete in the NFL or the National Hockey League and you've had a cord injury, even if you fully recover, you will not be insured. Your career is over. It doesn't matter what the doctors say. You will not get insurance. That's where the legal stance is now, because there have been several extremely expensive lawsuits that have occurred as a result of this. And then, for the amateur athlete, it becomes a bit trickier. So you then need to evaluate this. And I think that the presence of signal change in the sport, and again, assessing the degree of violence of the sport is involved. A lot of judgment and there's a lot of new knowledge that needs to be acquired here.
Okay, Ben, I think I have a question for you, if that's all right.
Sure.
So you've mentioned that awareness is your primary goal or the primary priority from James Lind Alliance, and obviously you've done lots of publishing of papers and podcasts on myelopathy.org. But how do we feasibly change awareness in primary care? You know, there's a diversity of practitioners, different pathways, regionally. You know, how do we change it?
I mean, I've got lots of ideas, and I keep trialing them out. I mean, Dr. Failings has got tremendous experience of going around the world trying to promote messaging in spine surgery. I've recently come to the conclusion, as very much as Mark has just said, that actually the key is to educate the patients. If you can get people coming into the room, asking the right questions, thinking about the right things, then they will change the behaviour of the clinician. And ultimately, they are the most motivated individuals to find a solution. They're Googling, they're searching, you know, they're slowly getting worse, they want an answer. And I think it's about that. You know, I don't think we need to ask GPs to know about DCM. We just need them to be able to think about it and make the right decision. Refer to MSK, MRI, and then you get closer and closer to people who are familiar, who are listening to these talks, perhaps. So I think it's the patients, to be quite honest. How do we get there? Well, I think we've got to bring people together, raise a lot of money, and keep working hard. But I think it's the patient education that's the key thing. Yeah.
Thank you.
Great. I think we're bang on time, so I want to thank the audience for attending this Society of Back Pain Research sponsored session. I want to thank the presenters for making the time, and indeed for the discussion from the audience as well. So thank you very much, everyone.